There are two main types of cancer, benign and malignant. In general, can you just tell me, or just say out loud, what are the characteristics of benign neoplasias? So in general, they're very slow-growing, round, symmetrical, well-differentiated, and oftentimes they have a fibrous capsule. And so just my reasoning for why they have a fibrous capsule, I'll say real quick, it's not in first aid, but so what cytokine is responsible for inhibiting cell growth? It's TGF-beta, remember? We just talked about it. And what does this also do? What does this cytokine do besides inhibit growth? It also stimulates fibroblasts to make collagen and connective tissue. So I think that the macrophages in this person's body are telling these cells to stop growing, but they're also stimulating fibroblasts to surround it with a fibrous capsule. I encourage you to always ask why and try to come up with reasons for things, why they are the way they are, and help you remember them, not only for your test, but also just the future in life as a doctor. So it always helped me to ask why for almost everything in first aid. All right, and so some features of malignant cells. They're usually irregularly shaped, necrotic, fungating, just ugly looking in general. And are they slow growing or fast growing? Fast growing. And do they metastasize? Yes. So they metastasize. That's why they're malignant and bad. And in general, what do benign cancers end in? What suffix? Oma. And malignant tumors, if they're of epithelial origin, what do they end in? Carcinoma. And if they're of mesenchymal origin, sarcoma. And in general, where do carcinomas spread to first? So they spread through the lymphatics. In sarcomas, they're a little bit deeper. They'll spread hematogenously or through the blood vessels. There's some exceptions to this rule, but in general, that's what happens. So now let's talk about the progression of how cells become cancerous, and we'll address the question that we just talked about. So here we have an epithelium, and we have stem cells here. By the way, what three tissues do you have stem cells in? One, skin. Sorry, skin. Two, your GI and your crypt of Lieberkühn, and three, in your bone marrow, the hemopoietic cells. So we'll just say we're talking about skin here. And as you can see, there's a basal layer, and it progresses to an apical and more differentiated, flattened out squamous layer. We have a basement membrane here with probably connective tissue underneath it, and this is either a lymphatic vessel or a blood vessel. All right, and so this is what normal epithelial tissue looks like. Now, let's go through some of the reversible changes, pre-malignant changes. So what's it called when you just increase the number of cells? That's easy. It's just called hyperplasia, or increased growth. What about, and this is in regards to our question, when you replace one adult cell type with another? And for the example we had was in the main stem bronchus of this person, of the smoker. This is called metaplasia. And so why does your body do this? First of all, what's the normal lining of your main stem bronchus? It's ciliated pseudostratified columnar epithelium. And when someone smokes, this smoke actually irritates this lining, and so your body wants to protect itself. Your bronchus wants to protect itself, and so it makes the squamous epithelium. And so this better shields the bronchus from the smoke irritants. Okay, and another example in the lower esophagus, I don't know if you guys know the name of this. It's called Barrett's esophagus, and this is a similar mechanism. It's just whenever you have irritation, your body tries to protect itself if it can. So the normal lining is squamous epithelium of your lower esophagus, and if there's irritation, such as from acid in your stomach in a person with gastroesophageal reflux disease, your esophagus will transform into columnar cells, adenocolumnar cells that produce a protective mucin so that the acid can't damage them. But the problem with this is that in order for these cells to transform from the squamous to these columnar cells, they had to actually undergo changes to their DNA. Anytime you mess with the DNA of a cell, you run the risk of progressing to cancer. So that's the problem. All right, how about if these cells start changing their shape and become a little lost with their differentiation, with their orientation and size and shape? They're just a little bit confused about who they are. What's this called? Dysplasia, or abnormal growth. And that's what I think of it. I think of these cells as being almost delirious. Like they're just a little bit confused. They don't know really where they are or what they're doing, but they can return from this abnormal state of mind. However, if we start talking about some irreversible changes, this is when cells can't change. And this is like, for example, they develop dementia, where they permanently don't know who they are. And so when we see this, when we see cells lose their differentiation completely and have this very high nuclear to cytoplasmic ratio, what is this called? They almost resemble their primitive tissues. This is neoplasia, or carcinoma in situ. And if they keep progressing, if these cells progress, are just clonal proliferations, uncontrolled clonal proliferations, it's called neoplasia. All right, how about if there is associated fibrous tissue? What's this called? Desmoplasia. And the mechanism for this is what I think of it similar to the benign tumors I talked about, is just macrophages in tissue making TGF-beta, and to try to inhibit these crazy growing cells, but they also stimulate fibroblasts to make this connective tissue. All right, so let's say that, by the way, what is the normal thing that connects one cell to another? Cadherins, right? So let's say these cells start losing their E-cadherins. It helps cells adhere to each other. They lose these, and they're able to move away and sort of army crawl their way to the basement membrane. And then once they reach the basement membrane, they synthesize these enzymes that degrade the basement membrane, and it has to be type 4 collagenase enzymes, right? And maybe hydrolyses degrade the basement membrane and then are able to leave actually through either the lymphatics or bloodstream and go and seed other tissues. What's this called? Metastasis is the answer. And so, but once they leave, they have to have receptors for other tissues, right? And so they'll have like laminin receptors. And once they make it to the other tissues, they're going to need a blood supply. So what growth factors will they need to synthesize their own blood supply? Remember we talked about this? VEGF and FGF. Good. All right, so those are some of the premalignant changes that occur. And real quickly, we'll talk about grade versus stage. Just in general, grade is what is the appearance of these cancer cells and what it looks like. How differentiated is it from its original tissue? So if we look at these high indice ratio cell, anaplastic cells here, they don't resemble the original tissue at all. So they have a high or low grade, have a very high grade, and they'd be like grade 4. Usually it's from 1 to 4. That's not as important as stage. Stage is the most important prognostic factor. And how do we stage cancers? On what system? It's a T and M system. T stands for tumor, basically, with the size of the tumor. N stands for nodal lymph node metastasis. And M is just for metastasis outside of nodes. And so which letter is the most important for a person's prognosis? It's M, or metastasis outside of nodes.